It's a good segue to the next segment. You made a reference to the changes in the reimbursement environment also having an impact on changes in the practice environment. We've seen the administration lay out a roadmap to try to migrate away from fee-for-service into different kinds of value-based models like accountable care organizations, bundled payments. Can you talk a little bit about what is the administration talking about when they talk about this move towards value-based care? What are these constructs, and what is the intention here? What is the goal?
So I think the broad goal, and everybody's heard kind of this notion of moving towards value. Value is not very well defined, except that the administration got a big boost in the form of legislation that was signed by the president this year to change and kind of modernize the way we pay Medicare, MACRA, and so the Medicare and CHIP Reauthorization Act. And I think that has helped to also give some wind to the sails of what the administration is trying to do. Roughly speaking, it's really trying to change the underlying infrastructure of the model for payment in fee-for-service, which has generally been kind of value productivity basis on some sort of estimation of time and complexity, and moving towards, honestly, you could argue that this is kind of moving back to the managed care era of like the 80s and 90s, but it's actually moving, I think, to having physicians and other clinicians working together as a group and managing the health of a population, all at risk under some sort of global payment structure. If I had to kind of do ends of the spectrum, I would say that that's what we're sitting at, is kind of the current state of fee-for-service, where the more you do, the more you're paid, to another spectrum where you're almost forcing kind of an interdisciplinary approach to try to manage the health of a population. That is not something a consumer understands well, and I don't think that the time pressure that we have to do this, basically over the next 3 years, to carry out all of this and get doctors and other clinicians and large hospital systems to think differently about their payment structure, is certainly much faster than I think anybody is ready for. But it's certainly a very, I think it's an important transition. I think it's going to be, like all transitions, pretty ugly, and that's exactly what we're seeing even with the accountable care organization space. So I don't think Medicare will mandate, because it's not Medicare's nature to mandate, but I think that the way they'll kind of mandate it is by saying that an ACO will qualify for that the proportion of your patients that have to be at risk, and we are all assuming what that means. An ACO will qualify for that, and so that's the part that I think is going to get to an unmandated mandate.
Right. It's fascinating, because I think the hospital administrators and system administrators of integrated delivery systems have seen that there's fewer healthcare dollars, and that the only way to get more of those healthcare dollars is to go at risk. One of the unintended consequences, I think, of the Accountable Care Act is that we've pushed a lot more money into healthcare systems, and around the country, hospital and system profit margins were as high last year as they've ever been, and it's really taken away some of that momentum to become an accountable care-like organization. And the other irony of this is, and whether this be in a global accountable care strategy or in the Medicare oncology care model, is that right now the arrangements are for gain sharing only. And the behavioral economists will tell you that you work a lot harder when you got something to lose than when you've got something to gain. And I think to prepare oneself to take risks takes a lot of work, and in an arrangement where you have nothing to lose, I don't think people are going to work as hard. And whether or not they'll be ready to take on risk in 3 years if it's mandated is a big question, especially now that we've taken away some of the imperative to take on risk.
And you can look at surveys, but you can also just look at actual accountable care organization experiences. 96% of the organizations are in kind of this one-sided, in general, that upside, less risk option. And in fact, there was a lot of pressure on the administration recently to allow for a longer time period to be in that, upside
gain only.
Well, and I think that's because if you look at in the Pioneer experience, you see actually big health systems like Dartmouth, Hitchcock pull out. And so we've had a number of pull out because they realize, I think one of the biggest things is, John, you actually mentioned it, gain sharing. We've had many discussions about this. In true gain sharing, you're competing against yourself. and you realize after 3 years, you can't compete against yourself anymore. So even CMS is looking to change the regs and make it more shared savings, where you compete against a market basket of others. So you said, I'm going to be better than sort of this regional basket or national basket, but the ACO experience is a little disconcerting when you think about it, that there's been some successes, certainly working together and things like that, but it's only a small, very small population of Medicare, no matter how much it gets hyped. And you do see on the Pioneer side where they went into it saying, we'll take more risk because we'll get more reward. They're realizing that they can't do it. I think Dartmouth, they're going to have to pay back $4 million.
Right. The birthplace of the modern ACO, Dartmouth,
right.
pulled out of the program. I mean, it does seem like the ACOs, you hear people now saying in Washington that the ACOs was sort of an interim step to try to prepare providers to be able to take risk, but we never intended ACOs to be the ultimate model that where the marketplace ended up.